Well, first of all, it's a great honor to speak here at the very first Pride Talks of the Leiden University in this beautiful room. What I want to do today is to show you some of the struggles we meet every day in helping transgender children and adolescents during medical treatment, also during psychological treatment. Although the Netherlands is really one of the first countries who started treating young people with hormonal treatment, there's still struggles around the world about this treatment, and I will take you through these struggles and especially how to deal with them as a physician in my case. So, just as a starter, of course, when a child is born, everyone asks, is it a boy or is it a girl? And maybe one of the main achievements would be if we stopped asking this question at birth, because, you know, you could be a boy or a girl, anything in between, non-binary or whatever, but the question really still reflects the perception of sex and gender as an unchanging binary biological reality. And that's also how we get trained in university, in medical school. So gender development after birth, how it is often trained is that you have men and women, that you have male gender identity, female gender identity, and male role behavior and female role behavior, binary constructs. But as most of you know, and I always like to use this picture, and I hope many of you know this picture, and otherwise please look it up at the internet. It's freely available also for all sorts of education in PDF and other formats, the genderbread person. Because what is really the case is that we don't have men and women, we have a mixture of everything. So gender is much more than only your sex or your identity. Most people think of gender as their sex, so their genitals or the way the body is formed, but it's only one part, so the biological sex, which can be more female or more male, but it has nothing to do in the end with your gender identity, so your innermost concept of yourself as being male or female or non-binary, something in between. So if you look at this picture, you start to imagine yourself in these four concepts, so of identity, your attraction to people, your sex and your expression, you will see that everyone around you is different. And if I teach students, this is always my first and last statement. Please look at yourself and look at your friends, talk about where you fit in, and then you will see that everyone is different, that you can be sexually attracted to somebody but not romantically attracted to the same person, that your gender expression can be very feminine, but your gender identity is male, and everything in between. And the thing is, and that's why I love pediatrics, is that children and adolescents are learning this, they are developing their identity in all these concepts, and it's not static at the moment that they reach puberty, and it's not static when they're 18. It's still developing for many people, and if they look at this picture, they start understanding themselves. So one of the main things and one of the main ethical questions in treating transgender children and adolescents is whether at the time they come to our clinic, they truly know about themselves, how they fit in the genderbread person. And that's one of the main things we talk to them, with them about. Who are you? Who do you want to be? And how do you picture yourself in more than 1 year? And it's a development, and I will come back to that later. So what we see also in medical schools is that there's more and more teaching in gender identity and a recognition of a non-binary world. Really, we don't only see that in medical school, but also in society. So in the Netherlands, the second person had a passport where no sex was assigned. And also in gender dysphoria, we see that more and more recognition of this non-binary world in which gender dysphoria now is not a disease or a disorder anymore, but is seen as a condition that may or may not need medical intervention. And that's really progress, that we can think about this this way, and that we can help these people. So there's progress, and I think this progress is not from the last years, and it didn't begin in the Netherlands. As a pediatric endocrinologist, we always say it all started in the Netherlands. It's not really true. It's not a new phenomenon. Also, the treatment is not really new. So one of the major achievements was by Henry Benjamin already in 1948. He started a clinic in San Francisco. The first clinic in the Netherlands was there in 1987 in Utrecht. In 2002, this team moved to Amsterdam, to the VU Medical Center, and there for the first time, so this team treated children and adolescents also, but only from a psychological point of view and social transitioning. And when the team moved to Amsterdam, for the first time, a pediatric endocrinologist got involved, Henriette de Lemarre, and she was the first one who said, okay, but I can also treat children with puberty suppression and cross-sex hormones. So she made the big step of also treating young people. Henriette de Lemarre went to Leiden, fortunately for us, and so she started a team here in Leiden. So at the moment there are 2 gender clinics for children and adolescents in Amsterdam and in Leiden. This is a picture of the Leiden team. And sadly, Henriette de Lemarre passed away in 2014, and she's been the biggest force behind medical treatment, hormonal treatment of children and adolescents in the Netherlands and later on all around the world. So I would really like to dedicate this talk to her. So if we look at gender dysphoria, just for the people who are not really familiar with what it is, so you have a gender dysphoria for definition in the DSM-5, which is a classification, psychiatric classification. So at some point people started discussing, should gender dysphoria still be classified as a psychiatric disorder, and it's sort of is going in the same way as homosexuality, which was also in the DSM until the beginning of the 80s. So there was a big discussion, gender dysphoria, it's not a disorder, but what would happen if it's not classified anymore in any classification? What to do with insurance? So as a solution, people thought about changing the name. So the name was gender identity disorder, and people changed it into gender dysphoria, so it's not a disorder anymore. It's a condition that could need medical care. And you have a difference between your experience or expressed gender and assigned gender at birth. and significant distress or problem functioning. And that's an important thing to underline, that there. So in the classification it says you need to have distress or problems functioning. But nowadays, especially in the Netherlands, when there's a lot of positive attention to gender dysphoria, young children who come out, they socially transition rather easily, and there's no distress. We see a lot of young children without any distress, but they surely are gender dysphoric children. So what to do with the classification if there's no distress anymore, because we are so accepting of these people? Not always, of course, but so it's a minor issue in the classification. And with the recognition of the condition that could need medical treatment, guidelines came up. So the first guideline was the Dutch guideline from Amsterdam, from Henriette de Lemarre, but soon international guidelines followed, and because it's a hormonal treatment, these guidelines are written by pediatric endocrinologists or adult endocrinologists. And the main objectives always are to describe what care is needed, and it's always mental health professional together with an endocrinologist. And for children, and especially adolescents, so who reach puberty, it encompasses suppressing puberty first, and then treating with cross-sex hormones, so the hormones of the affirmed gender. And in adulthood, surgical treatment can follow, but a lot of adolescents, they don't follow up with surgery immediately when they become 18. So top surgery is one of the things trans men really want, but especially genital surgery is something they postpone often. So the Dutch protocol follows these guidelines, and we sort of have strict criteria for treating children and adolescents. So you need to have a lifelong gender dysphoria following the criteria of the DSM-5. And what is really important, we don't hormonally treat children who did not reach puberty yet, because there's nothing really to treat at that moment. But when puberty kicks in, what we have to see is an increasing distress. So the body is changing, not towards the affirmed gender, and we need to see distress coming from that. It's one of the criteria to start hormonal treatment. And one of the other things is that we really look at that there's no severe comorbidity, psychopathology, and a good social network, because this treatment is not only taking a pill or an injection, it's a complete transition, which of course takes a lot of time, effort, emotions, and you really need to have good support. I will go into that later. So in the Dutch protocol, we wrote down that we would start this treatment from the age of 12. We know that especially birth-assigned females come into puberty much earlier, around 10 years of age, 10 and a half. But first we said, okay, you need to be 12, and then we can start puberty suppression. So the body has already changed 1.5 years due to estrogens before we can start treatment in birth-assigned females. And we start with puberty suppression and not directly cross-sex hormones because these people are so young, and what I showed you in the gender-bread person, they are developing their own identity on all these 4 scales. So we need time to make a balanced decision, to talk through what identity people have, who they are, who they want to be, but by suppressing puberty, there is much less distress about your body changing. One of the side effects, positive side effects, is that you have much better results when you start gender-affirming hormones, because the body didn't change yet, so you didn't get a very male or female body. So that's a positive side effect. So, in short, we have 3 phases. We have a diagnostic phase when a child comes in. It takes about half a year to talk to the child and adolescents and to really establish that there's gender dysphoria. Then we start puberty suppression, what we call an extended diagnostic phase, because we keep on talking, of course, to the adolescents how the future will look like, and then at some point, which is most of the times 16 years of age, we start cross-sex hormones. These are the hormones we mostly use, decapeptyl, and of course in the testosterone and estrogens. So, and now you could say, okay, there's a protocol, it's internationally acknowledged, written down in famous articles, in famous journals. So what is the problem? Because just follow the protocol and then anything goes. But what we see as treating physician and also psychologists and psychiatrists is that you really have to be an equilibrist in every treatment, because it's not so easy. The protocol is being criticized as too conservative by many support groups who say, okay, why do you start at 12 when this birth-assigned female is already into puberty 2 years? Why didn't you start earlier? Why do you start at 16 with cross-sex hormone? Why can this trans male not get his top surgery at 14? So there's a lot of pressure that we're being too conservative. Then on the other side, we have our colleagues, medical psychology colleagues, who say, you are much too liberal. These children, the gender-bred person, they're still developing their identity. Who says that in treating these youngsters, you're not pushing them into the gender dysphoric pathway? Maybe if you would just have waited, they would, in the end, be cisgender. And there is this one very important thing I always stress, is that gender is a very important part of your identity, but there's more to your identity than gender. And that's also developing during puberty. And you can't stand still and have your transition and not work on anything else, like your education, like your place in the world. And as a pediatrician, we also have to look at that. And that means that we have to weigh all these factors to come to individualized treatment for every person. So just to show you what's happening in the world in this discussion and weighing of all these factors. So first, the support groups who say we're much too conservative. So what I already said, there's a lot of positive attention in social media, which means also that there is a great rise in people coming to the gender clinics. This is what we studied in a questionnaire in Europe and the USA. Great rise in people going to, so young people going to gender clinics. And what happens is that we get waiting lists. So the waiting list now is about 1 year. There are more than 500 young people on the waiting list, so they didn't see any psychologist yet. And it will take so 1 year to see a psychologist, and then at least half a year to start treatment with the endocrinologists. So there are discussions with the support group, why do we need the psychologist? So if a person comes to me and says, I have a transgender identity and I want hormonal treatment, isn't that enough? And they call it the informed consent model. So no diagnostics anymore. The person sitting in front of you knows best about the identity, and we start treatments. No waiting lists anymore. This is a bit difficult to read, but what many of these support groups even say is that if I wouldn't start hormonal treatment this way, it would be dehumanizing. So people are saying to me that I am working in a dehumanizing way, which is sort of a shock to hear when you try to do your best for these groups of people. But that's how it works when activists groups are so emotional, for example, about the waiting list. And it's of course, we can understand that this happens. What we also see in the Netherlands, so the Netherlands started this protocol and is really sort of fixed to the protocol, but in other countries, it's more liberal. So I see patients, trans male patients who go to America when they're 14 or 15 years of age, and they have their top surgery there. So their parents pay to go abroad and have their top surgery. There's nothing I can do against it. I don't support it because what I said, there's more to your gender identity than only gender, and the complete focus on the transition often makes that these young people don't go to school because they're going to America to have their top surgery. But these things happen. And then you have the medical community who has a totally different view. We studied with Lieke Vrouweraad, who's in the audience somewhere over there. We studied the unease that medical teams have in treating children and adolescents with gender dysphoria. And one of the main issues was that we still don't know the nature of gender dysphoria. So where does it come from? Why does it happen? We also don't really know what the role is of your physiological puberty, so just going through the puberty of your birth-assigned gender in your gender identity. What happens if we stop at the beginning of puberty, we stop the physiological puberty? What happens to your brain development? We don't really know. We do it, but there are no long-term outcomes of that. One of the main issues also of all these teams is, can these very young people decide over their future when they're so young? And these are all issues that play within the teams who do the treatment. So one of the things I said to you, we don't know what the etiology of gender dysphoria is. There are a lot of factors possibly playing a role, amongst which also cultural factors. I'm sure of that, but we don't know what the interplay is with genetics or development of the brain in utero, for example. What we do know, and these are very interesting figures for me, that if you have a child with gender dysphoria, so pre-pubertal, only 20% of these children persist. And also in adolescence, when puberty kicks in, they still have gender dysphoria. 80% doesn't persist. And they turn out to be homosexual, most of them. These are important figures, and also to bear in mind not to start treatment before puberty has kicked in. So in America, there's a lot of question about, okay, why don't we start before puberty so that they will never know the puberty of the birth-assigned gender? But we say, no, don't do that, because 80% will not persist. What we also know is that there is an overrepresentation of children with autism in the gender dysphoria group. We don't know why. In the Netherlands, we say, okay, it can be present in one person at the same time, but there are two different things. But there are also opposing opinions. So people who say the cross-gender behavior can be attributed to the specific interest of people with autism, or is a factor of obsessive-compulsive behavior that we also often see in children with autism. It's interesting to think about it, but we don't have any clue how this all comes together. What we do know, in Amsterdam it was studied, and now we also study it in Leiden, that the vast majority of adolescents who start with puberty suppression go on to use cross-sex hormones. Is that because we diagnose correctly, so that we're so brilliant that we know of all these children, okay, so they persist, and they all go on into cross-sex hormone treatment? Or is it because we did something with their gender identity development and they go on in the line we push them? We don't know. All questions that go through your mind every time you start treating an adolescent. So, just to show you what happens when you use cross-sex hormones, these are pictures taken from the internet of a trans boy who shot photos of every moment of his transition. This was before starting cross-sex hormones, and when he started on testosterone, you see the body change, more male-like. In the second picture, he still has his breasts. They are removed at some point, and in the end, it's a very male expression and body composition. So this is what happens when I start testosterone treatment in birth-assigned females. But we don't really know for the long term, when we do that, if it has major physical side effects. We know for the short term that there are no real safety issues. We know that we can easily suppress puberty, no problem. It's no rocket science at all, the medical treatment of gender dysphoria. We can give testosterone estradiol, we see the bodies change, but what happens on the long term when you suppress puberty? Puberty is very important for your bone health, so we stop bone composition for a relatively long time. What happens in the long term when you're 60 or 70? Will you break your bones much easier? There are cardiovascular risks to using synthetic hormones, and what I said, we don't know about brain development. So what we do now is we counsel these children and adolescents about what we don't know, and there's a lot we don't know. But they still all take up the treatment because they don't feel they have any choice. One of the major things, and it's always on my mind, is that in the end, when I start the treatment, all these children and adolescents will become infertile. And of course, the trans women can easily bank sperm if they want to. I say they can easily do that, but for them, it's most of the time a major problem. So we looked at our own population where we studied 35 trans girls. More than 90% were counseled about the possibility to bank sperm. Only 36% of them attempted to do that. For most of the trans girls, the idea of masturbation and ejaculation is too much to handle, and they don't want to, so they don't bank. And some do attempt, but then it is not successful.
We're running into the question time.
Yeah, I'm always ready. So what we see in our own medical community is that there are, and especially in the last months, there are more and more critics about the treatment we are giving. Not only within the medical community, also parents who start discussing what are you doing to our children. In England now, there's a big discussion about a research study they are doing, which is not at all different to the treatment we are giving now in the Netherlands, but it gives a lot of discussion. And lately, also our colleagues, pediatric endocrinologists, are writing letters and editorials to our medical journals to say you have to stop these treatments because it's not an endocrine disorder, but you're giving these adolescents an endocrine disorder because you're making them infertile, you're jeopardizing their bone health, etc. So that leaves us in a very difficult place with the support groups asking us to treat younger and younger, and our own colleagues saying you have to stop the treatments. And there's one other thing I was already saying. There's more to your identity than only gender. We know of transgender people that they have more social mental problems. There's much unemployment, depression, suicidal thoughts. What we heard, harassment, victimization. I think it's also my task to give these young people healthy coping mechanisms because they will enter the world as an adult with this facing them. We know, even in the Netherlands, which is very progressive, we know they will face this. And if they need also to develop healthy coping mechanisms during our treatment. So there's more than only the physical transition. So we have to take into account the long-term physical consequences and these coping mechanisms. I think people have to complete their education. So you cannot, there are a lot of young people who say, okay, I will stop my education, do my transition, and then everything will be okay. We know people will not be okay because they didn't learn the healthy coping mechanisms and they will not start any education anymore. They fall into a big hole when the transition is over. Transition is a phase and your life is forever. So that's also something we take into account. So we hear these children and we hear these young people and we really try to help them. Sometimes what we advise is not really what they want to hear. It's not what the support groups want to hear. On the other side, it's not what our medical colleagues often want to hear. So we have to be equilibrists in all these factors, which makes it really, really a great place to be. And I wouldn't want to do anything else as a pediatric endocrinologist. Thank you very much.
So we have actually gone over time, but of course we will stay a little bit longer, as I'm sure there are questions. So 1 or 2 questions for Professor De Vries. And Jeroen, will you do the honors again?
If you shout really hard, maybe I can also hear it.
Okay, try.
Thank you very much for the lecture. With interesting facts on dysphoria and
You can only ask one.
Yeah, very good question. So the easy answer would be, but I think it's also the right answer, that it's really multifactorial. So we've done functional MRI studies and we couldn't find real answers. We did genetic studies. It's all associations. So it's I think it will be very difficult to find one answer, and I don't really care actually. So, and about the education, you're absolutely right. If you see, especially in the adult population, so general practitioners, for example, who don't know how to deal with trans women still having a prostate, trans men still having a cervix, and they need preventive care. So when you change your sex in your passport, you don't get calls for your preventive cancer checkups. So these are all things we have to bear in mind. And if we think about that, about 0.5% of people identify as transgender, then it is a serious health issue, I think. Yeah.
But isn't the question then really where does gender dysphoria come from, or where does gender come from? Because the question about gender dysphoria means that cisgender is the norm, right? And that's maybe what we also want to get away from.
So that's what I always do with the genderbread person, to show that, and that's also the problem with still the definition of gender dysphoria, because we know of places where, and they call it a third gender, where people who live who don't identify with either male or female, but they just, they blend in. There's no problem. There's no dysphoria. We see it in the young children who are socially accepted. So it is an issue of what is gender, what is your identity, where is it built from? Yeah.
Okay, one more question. Go ahead, just, in the white shirt. Yes.
Yeah.
Thank you very much for very interesting presentation. I'd like to ask you about what would be the best way to treat transgender children before puberty. As I told, they are not medical interventions necessary, and there are also like many other issues other than like physical limitation. And medical professionals are most knowledgeable expert nowadays, but I think all those issues are not necessarily dealt by medical professionals, especially thinking about this long waiting list. So, but if children probably have gender dysphoria, parents might come up with the idea to bring that children to hospital at first. So what would medical professionals do?
Yeah. So in the Netherlands, we have the, in my view, perfect situation that we always work multidisciplinary, and these young people who are not in puberty yet are not seen by me, by the medical endocrinologist, only by psychologists, and we advise them on how to live really at home, at school. We can give them addresses of the support groups who help deal with the dysphoria, who talk about how to transition if you want to transition. We always advise not to completely socially transition when you're so young. So you can do that in a safe environment, at home or with friends where you feel safe. But, for example, to not do it at school or at your sport, because we know that more than 80% don't persist, and then you have to change back. So there are a lot of advisory support groups on that, at least in the Netherlands. Yeah.
We're going to leave it at that for now. I will have a few concluding remarks, and let's give another applause.